My name is Carol Herbert, and I'm privileged to chair this afternoon session. My role is, I'm a retired family physician, and I'm very, very sensitive to this particular issue that we'll be discussing this afternoon. But my role today, for the reason why I'm the chair of this panel, is because I'm the president of the Canadian Academy of Health Sciences, which is a national organization, which is an honorific organization across the health disciplines, and provides, from amongst our best brains, provides evidence-based assessments on issues that matter to health of Canadians, to a variety of constituents, including government, but it's an independent organization. So I'm delighted to be here and really looking forward to this session myself. We have two presenters this afternoon. Our first presenter is Sarah Bennett Fox. Sarah does not have a bio in your handout, but Sarah is the daughter of Gillian Bennett, who is a recent pioneer in this evolving area of decisions around personal choice and time of death. And she's going to provide some reflections on her experience, her family experience, from her mother's experience. Thank you.
Thank you very much for inviting me here. I'm honored to be here. I'd like to acknowledge that we are on West Coast Salish traditional lands, and we are privileged to be here. My name is Sarah Fox. My mother was Gillian Bennett. My brother Guy Bennett's here as well. And my mom chose to kill herself on August 18th, 2014. And I just wanted to frame perhaps a little bit my mom's attitude towards suicide, because my mom did commit suicide. It says so on her death certificate, and she was very open and comfortable to use that phrase, although we might want to question that as time moves on. But my mom did not have my mom was not pro-suicide at all. My son died when he was 8 days old, nearly 21 years ago. And the day after my son died, my mom sat me down and she said, "There are two things you may not do. Two things. You may not go crazy, and you may not kill yourself." And I said, "I understand, Mom. I got it." And I did get it. And yet, there was myself in so much pain, and it would have been wrong for me to kill myself. And 20 years later, there was my mom, not in abject physical pain, able to bathe herself, make a great cup of tea, make toast, toilet herself, live at home, probably not going to die naturally within 6 months, and yet she chose to kill herself. And she thought that was okay, and I think it was okay too. And that's been a journey for my family. Oh, these are just photos I thought you might like to see. There's nothing, there's no poems or special quotes, just there if you wanted to see a little bit about my mom. Our family's journey, well, it began there when they got married, I suppose, 60 years ago. But my family's journey with end-of-life choice began decades ago. My mom announced, "I won't be one of those old people growing old as a vegetable. I won't do that. I will take matters into my own hands." And I wondered at the time, when you're one of those old people, Mum, let's see how that plays out. It'll be interesting. Well, fast forward a couple of decades, my mum's pretty old. Ironically, she doesn't have a physical ailment. She has dementia. My mum had dementia. She couldn't remember how to use the space bar on the computer. She would produce uncooked fish, whole, for lunch and announce that we'd always eaten it there. I mean, there were many symptoms. But she had dementia. She knew she had dementia. She absolutely stuck to her choice, the choice that had been hers for decades, which was that she was not going to grow old as a vegetable. She would be happy to grow old, not as a vegetable, but not as a vegetable. Harsh words, they would have been hers. And so she had to end her life sooner rather than later. And my mom took Nembutal. She got it illegally, presumably, because you can't get it legally. She had to act on her decision at a time that she could remember her plan and that she could take out her plan. There were many risks involved in this, none of which my mom appreciated. My mom thought that she had done absolutely everything to make sure that myself, my brother, and our dad didn't get into trouble, and indeed, that was the case. She had arranged that. She took plenty of risk in taking an illegally acquired drug. Obviously, that Nembutal turned out to do what she wanted it to do. It might not have. She took the risk every day that she delayed taking her life. She took the risk that that would be the day she forgot the plan. That would be the day she remembered the plan but didn't remember where she'd hidden the Nembutal, or that would be the day she didn't remember how to mix it and what to do with it. So she took risks. It worked out the way my mom wanted it to, because that was her choice. And this is what I want to talk to you a little bit about, because I've had the chance, the privilege, to read more than 1,000 emails that have come into my mom's website, which is deadatnoon.com. That was my mom's chosen name for it. Gives you a bit of a sense of my mom. And I've answered each of those emails. There are more than 1,000 of them. So I've heard from many people, profound stories, beautiful stories, heartbreaking stories. Mainly heartbreaking stories have come in. Stories where the common denominator is that people have had an end of life that was not of their choice. It was not of their choice. And that's what's made those stories heartbreaking, not because their end of life was different from what I might choose for myself, or from what my mom chose for herself, or what you might choose for yourself, but because it wasn't what they chose. I've heard from so many husbands, wives, children, sisters, a couple of times from parents whose loved ones have been suffering horribly. People know this is not what they wanted, and they couldn't legally do anything about it. They could do nothing about it. And I think that the common denominator, which is that the end of life should be in accordance with that person's choice, that to me is key. I've come to see that that's the key. Not that end of life should be without suffering, not that heroic measures should not be taken, but that in each case, the best thing is for end of life to be in accordance with that person's choice, this person's choice, your choice for your life, my choice for mine. I've come to believe that. I may be wrong. You have a lot more expertise than I do, but that's what I believe. So then we come pretty quickly, we run into the brick wall of what happens as we lose our cognitive abilities. And of course, as a child of someone with dementia, I'm aware that my risk of having dementia later on, maybe tomorrow, maybe now, my risk is increased. We're all sitting ducks for it, apparently. We're all sitting ducks for dementia, and we all know what it means. We'll lose, among other things, our cognitive abilities. So how does choice look in that situation? Well, without advance consent, choice doesn't look like anything. It isn't anything because we're not given a choice. We're deemed to be too muddled, not worthy of having a choice of our own end of life. So I feel very strongly that advance consent is extremely important. I'm so unhappy that Bill C-14 is not including it. I think it's a big shame. I think it takes away the one simple thing that we could say would be dignified, which would be for each person's choice to be honored. I fear that if I get dementia, my choice won't be honored. But I also fear that if I get some other kind of ailment, stomach cancer, heart disease, gout, I don't know, something that we'd all agree, that's physical. She's going to think just fine all the way through that. Well, maybe not. Maybe not. I have migraines, not as often anymore, but when I have them, they're crippling. They're crippling. I'm sick as a dog for about 12 hours. I wouldn't really say that I could make good choices in that time. I wouldn't really say so. And I know from watching a friend's husband in the late stages of metastasized stomach cancer that a very clearly physical ailment can get you to the point that you could say, perhaps that person's not thinking so well. They have so much pain. They have so much pain. They're so sick. Perhaps they're not thinking well. So then I fear that those people's choices will be taken away from them. I fear for that, and I think that that's a likely scenario for many of us in our end game, that we are going to be either with obvious cognitive impairment because of whatever is afflicting us, or side effect cognitive impairment from the medications we have to take, or possibly from sheer pain, sheer nausea. So who speaks for us? You here, right here in this room, probably the most educated, thoughtful, trained people on this topic. But I don't actually want you to speak for me either. I don't want you to. I want to speak for myself. And I want me now to speak for me, those are my nephews, for me later. That seems to me the only fair way and the only right way. My mom would have been beyond thrilled that so many people are talking about end-of-life issues now. And I think there are many people in this room who've been doing it for many decades, and I acknowledge that, and I thank you for all the work you do. I do think there's been a shift in Canada in the last 2-3 years, partly because of the Carter family and the Carter decision, partly because of, for whatever reason, my mom's story sparked a chord with people. I think there's been a shift. People aren't so scared of talking about these matters now. I think that's fantastic. I think it's good to talk about them. I think it's healthy to talk about them. I think that the more people talk about them, the more people will go, actually, I do have a view about this. There is something I want to say about my end of life. And I want you, my husband, or I want you, my sister, or I want you, my children, to listen. No, listen to me. This is what I want. This little old lady, she said what she wanted. Oh my God, and she went and did it. Right? She did it. If she can do it, others can do it. I think that one of the great things about my mom is she was a little old lady. She was a little old lady. And I think that the fact that she could speak so openly about these things, I think that gives some more people courage. I'm not saying courage to take their own lives. I'm saying courage to have the conversation. Courage to speak their truth about what they want. And that's really all I wanted to say to you, except for one last thing, which is that whatever it is that you feel about Bill C-14, I hope that you have the chance, and if you haven't, that you do take the chance in the next couple of days to write to your Member of Parliament and tell them what you think about it, so that your voice is heard, because this next piece of legislation will impact a lot of people. Thank you very much.
So my talk will take a slightly different tone. So I'll be speaking as from the perspective of someone who's been involved in palliative care for over 25 years. I'm a physician. I started doing palliative care in South Africa and a freestanding hospice there, and have been doing it in Canada over the last number of years. And certainly have been involved in this debate at various levels over the last number of years. And my goal for this next 20-25 minutes was really to provide a bit of an overview and just some of the context and maybe some of the facts of just how this debate has been structured and just what is happening around end-of-life care in Canada. And then I think that will frame our discussion going forward. So I'm going to talk a little bit about the palliative approach to care. So I know you've heard a lot about that this morning, and I'm not sure, but I think it's helpful to say certain things again. Hopefully they won't be too much of the same thing, but it's just maybe putting them together in a new way. I'll talk a little bit about the current status around physician-assisted death or medical aid in dying, which is the terminology chosen by BLC 14, and so now in most of the different protocols and guidelines that are being written, that's the terminology you're seeing. And then I'm going to just frame it back to each one of us in terms of how can we better support each other as we age as a society. So question. How many in this room have experienced the death of someone close to them? I would guess that's all of us. For how many was that good? Was it a good death? So a minority. And how many, in many cases, did it not go as well as you had hoped? Okay. And so if you just think about that, what were some of the factors, some of the things that made it go well, or some of the things you wish had been in place so that it would go better? Any thoughts about that? Sorry? Communication. More communication? Went well. Yeah. Anything else?
Less stringent laws.
Less stringent laws?
The fear that pain medication might be addictive and that this dying person might be addicted.
Fears about addiction? Anything else?
Loss of dignity.
Dignity? Loss of dignity? Constant interventions that the medical system knew wouldn't work. Okay, so I think I'm sure if we had time to look at each of our stories, we would have very different stories. We would all have an experience. We would all have different ideas potentially about how to improve that. So as a society, as Sarah has framed for us, we are aging. And certainly in the statistic in 2030, usually that's kind of the age at which most of us are thinking, maybe, you know, the care that I need should be in place by that time. Fully 20% of us will be over age 65. And one of the other factors that's really impacting those of us in the healthcare system or around the healthcare system is that there will be way fewer caregivers, informal caregivers, than there presently are, about 4 to 1 versus 10 to 1. And dying is changing, whereas in the 100 years ago, people died usually of accidents and then of infectious diseases or in childbirth or trauma. Now more and more we're living longer with chronic illness, and more of us will have dementia. How many of you have read the book Being Mortal by Atul Gawande? Again, quite a number of us. And I thought it really was a very well-described story of how we as a society have medicalized aging and how we've medicalized dying. And I guess one of the things that sort of prompting sort of the approach I've taken in this talk is that as I talk to people all through the country, I was in a national role for a time, there's still lots of stigma, lots of fears, lots of myths about living with disease, living with disability, and then death. And I've heard somebody say, and I think it may be true, that we're not even so much afraid of death, but about dying, because it's something we haven't really experienced. We've seen some good examples, some bad examples, and so dying and then death. So this is how we die in Canada at this time. About 28.4 of us will die from what they're calling a terminal illness, which will be frailty or dementia, organ failure, so congestive heart disease, end-stage lung disease, kidney disease, a major organ failure, or terminal illnesses, cancer and illnesses like that come on quite suddenly and have a deterioration unto death, and then frailty being about 30% of us. In only about 10% of cases or less will we die suddenly in our sleep, without some kind of time ahead of us where we may know that the end is coming and may or may not have time to prepare for it. So we're saying in the palliative care community that about 90% of those who die could benefit from palliative care, and hopefully you'll understand why. But dying from these different trajectories looks quite different. So cancer is the darker line on the top, and basically we live with cancer, and then there's usually a point at which the decline is more rapid. And certainly the practices of palliative care have grown up around primarily the cancer population, where there was this defined stage at which you were palliative, and you knew it, and the treatments don't work anymore, and now you need to enter into this end-of-life phase. For many of us, and most of us, it will be more the red line, which will be this kind of sense that we're on the slower process of deterioration. So the usual 5-year mortality for congestive heart failure. There'll be complications. You may recover, but usually not to the place you were before. And then gradually things go. And then one day you're not able to kind of pull back out, and death happens. Or this longer frailty dementia trajectory where you've known for quite a long time, and I guess speaking to the fears that Sarah talked about with her mother. So in BC currently 38% of healthcare spending is on the last year of life. Of all deaths, as I said, 90% could benefit from implementation of palliative care, the palliative approach to care, and yet only 30% have access to specialized palliative care, about 55% to home care, and about 58% to a palliative care benefits program. Only about 14% of British Columbians have an advanced care plan. And when we've done a survey across Canada, and I was the lead for British Columbia, when we looked at what patients and family members told us they wanted about end-of-life care, and we looked at what the orders were in the chart, there was agreement between those two things only 33% of the time. We are not having these conversations. We also know that right now 55% of those who die in acute care. And we know that deaths in acute care are associated with the highest costs, but also the greatest suffering, the least quality of care or satisfaction, and negative health outcomes for bereaved family members. The intensification of care at end of life often leads to bereaved family members 6 months down the track having depression and even PTSD. Only 12% died in either hospice, 12% at home, compared to 29% in the US, and 10% in residential care. So what is the palliative approach to care, or palliative care? So it's a person, family-centered, evidence-informed care. It focuses on pain and symptoms because those are the things that usually interfere with quality of life. And by and large, communication is the key strategy. A focus on what are your goals of care, and a provision of a roadmap. Here's what's coming down the road, and here's how you can prepare for it. Here's the choices that you will be facing to enable people to be in charge and in control of what's happening. And I don't know how that line that didn't get completed, but affirmation of life. And choice, it could be a number of things, I guess. And support for a natural death. More and more we're hearing that just like there was a natural birth movement, there's a kind of a natural death movement, understanding that addition of technology and other things may not actually benefit us. It may actually increase suffering, but that we can allow death to proceed in a natural way. And this is our usual diagram, but basically I think when we've been engaging as the BC Centre with more of our public, one of the things that most people in the public do not understand is that at this time, just as the stat that I showed you shows, most healthcare providers do not know how to integrate a person-centered approach. They know how to manage diseases. And so without that foundational approach that asks, what do you want? Who are you as a person, and what's important to you? And then you walk that line with people as they go through their life, and you support them through that. I think we're facing a real crisis in our society. So a palliative care approach, as defined by the World Health Organization, is team support to help you live as well as you can for as long as you can. Central to the kind of philosophy of palliative care is that we neither hasten or prolong death. We accept it as a natural part of life. We accept that there's tasks, developmental tasks associated with dying, and we can support people through that time. We help the family cope both during the illness and in their own bereavement, and we know, based on what I've told you so far, that it needs to be integrated urgently into the care that's provided in all settings of care and for all diagnoses, for all trajectories, and by all providers. It's not acceptable that this type of care is not available to everyone who is dying. We also know that since 2007, increasing number of studies, so 7 was a few months ago now, there's 9 different studies showing that the early implementation of palliative care as compared to standard care, and this was really the first article, one of the key articles, and Jennifer Temmel looked at a group of patients diagnosed with lung cancer and compared usual care by Harvard-trained physicians, this was in Harvard, with usual care plus palliative care, and patients who had palliative care interventions had greater sense of quality of life, had improved mood, less depression and anxiety, and lived 3 months longer than the patients who did not have palliative care, despite having very excellent oncology care. And so that, I think, should give us pause about what does it look like to have a person-centered approach earlier in the disease trajectory, and why is that not more available? Joe was a man that I met on the Thursday just before Thanksgiving weekend. And he had spent the last 3 months of his life in the hospital on intravenous and various treatments which had not been successful. He had waited for quite some time for a procedure that was available only in Alberta, then that was not successful, and when he came to us, it was because he had chosen to stop all medical treatments and come to hospice, and basically for his end of life. When I looked at his chart, however, I saw a few things that gave me pause. One was that he really had a very slow-growing tumor, and his condition was really out of line with where he should be based on his diagnosis. There were things that I would have tried to do to help him have better quality of life that had not been tried. And so when I met him for the first time, I shared that with him. I said, when I look at your chart and the care over the last 3 months in acute care, there's things that I believe we could do to help you feel better. And, you know, we're on Thursday before the long weekend. Will you give me 5 days? Will you give me 5 days to see if I can turn things around, improve your sense of wanting to live this life that you now have? And if after 5 days you're no better than you are today, then I'm happy to support you in whatever way seems appropriate. And he said, sure, why not? So we started some palliative interventions. That evening he ate supper for the first time in 3 months. By the time I came back on the Tuesday, he had spent time with family. He had gotten out of bed for the first time in 3 months, and he was enjoying his life in a way he had not. 2 months later, he was discharged home. 18 months later, he died. So, what does that story tell us? We, through palliative interventions implemented appropriately, he gained 18 months. It's not about death with palliative care. It's about helping you live the life that you have and the quality of life that you should have in that life. And this is what our patients have told us over time that's important at end of life. Pain and symptom management, sense of control, clear approach to decisions and roles. What can I make decisions around? How does that work? Strengthening relationships, continuity of self before, during, and after illness, and to have a sense of meaning and completion. That your life and your death are consistent with who you are and the choices that are important to you. And to have time potentially to build in some life review, to find the purpose and the meaning in the process. And for all of us, that will look quite different. That mix of what's more important and less important at different times will look different. And so I believe, hopefully, I've demonstrated that palliative care is an important part of the continuum of end-of-life care. That introduced early, it can improve outcomes, and certainly tells you why I'm working as the Executive Director of the BC Centre for Palliative Care, working in the areas of research and innovation, working to promote uptake of advanced care planning by the public, helping improve access to hospice beds throughout the province, support for education and quality of care, We've released a seed grant program which is supporting local communities to do innovative projects to implement palliative approach to care, advanced care planning in their local communities. 21 hospice societies have had some funding. We've got 2 more funding releases to kind of make sure that throughout our society and throughout our communities, we're making these options more available in a kind of compassionate communities approach. I'm going to switch gears now and we'll look at some of the stats around physician-assisted death. So the global context, just briefly, we've looked often to Oregon because I think they have about the same number of deaths as British Columbia. They're the jurisdiction in the world that has had the Dying with Dignity Act since 1998. And the stats that we have, the ones that I had available, were from 2010. And physician-hastened death, physician-assisted death, medical aid in dying, accounted for 0.2% of all deaths. That's about 150 deaths in a population, similar to BC's, where we both have about 30,000 deaths a year. And in that jurisdiction, competent terminally ill patients can ask for a prescription from physicians. They then ingest that themselves. Most have cancer. 93% have hospice palliative care services, so just having hospice palliative care doesn't mean you won't want physician-assisted death. They're quite separate things, and most are highly educated. Euthanasia, which is practiced more in Europe, where a physician injects a medication, a series of medications to result in death within a 15-minute time frame. In Belgium, it's up to 4.7% of deaths. So quite a range in terms of what's available and how it's administered. In Oregon, the reasons people gave for requesting death with dignity or physician-hastened death or physician-assisted death were concerns about losing autonomy, loss of dignity, some of the things we've heard about in the room, less able to enjoy activities of life, loss of bodily function, their skills, their cognition, the things that were important to them, that they were perceiving they were a burden to their family. Pain was not a major issue. And most of the time when it was said as one of the reasons, it wasn't because of present untreated pain. It was because they were concerned that in the future there may be pain. And then financial issues, not very important at all. So this just gives you a sense of how it looks in Washington State. So over 2.5 years, one of the cancer centers had 114 patients ask about physician-assisted death or death with dignity. 38.6% after initial inquiry did not pursue it any further. 26% initiated the conversation but did not continue or did not fill their prescriptions. 35% took home a prescription, and 60% of those ingested their prescriptions. And so we see that out of all the people who were interested in finding out about this, 21% actually took the medication as a means of hastening death. These are some studies, and there's lots of studies, and so I've just chosen some key ones to focus on. Canadian cancer patients from across Canada, about 70% of them had no desire for hastened death. Out of those, 20% met criteria for a psychological disorder. 30% described that at some time they'd had a desire for death, and in 18% of those that was transient. It might be something like, I wish I was dead, I can't do this anymore, why is this taking so long? Those are the kinds of statements that were usually in that category. 12% expressed a genuine desire to die, and half of those met the criteria for depression or anxiety. And the other half did not. This was not coming out of any kind of mental illness or depression or anxiety. 39% out of that 12% would actually do something intentional to hasten their death or to ask for euthanasia. And again, so there is a level of depression amongst this population, and that's been confirmed in other studies. So I can talk more about that if people want to know about that. Certainly there's a physician in Oregon, Linda Gansini, psychiatrist, who's done quite an in-depth study of why people in Oregon are electing to hasten their death, and if that's of interest, we can discuss that later. So the Carter decision, February 6, 2015, a unanimous Supreme Court ruling that a competent adult with grievous and irremediable medical condition causing enduring suffering can give consent to the termination of life with physician assistance. The ruling was broad and covered both physician-administered and patient-administered hastening of death. So it wasn't clear on whether we're going the Oregon route where you get a prescription or the Belgium route where the physician administers or euthanasia. And implementation is delayed and is coming in about a month. So Bill C-14, we've talked about it briefly. April 14, 2016 was introduced in the Canadian Parliament, and they've chosen this terminology of medical aid in dying to be more consistent with the legislation in Quebec. Eligibility criteria, as we've talked briefly about, are capable adults with a grievous and irremediable medical condition who have serious incurable illness, disease, or disability, who are in an advanced state of irreversible decline and where natural death is reasonably foreseeable. It needs to be a voluntary written request with informed consent that's witnessed. There's a process whereby 2 physicians have to see the patient, and there's a lot of legal forms around how that is handled. So exclusions at this time are that mature minors cannot request this, that you cannot write this in an advance directive or in an advance request, and that mental illness cannot be the sole underlying condition. You can't ask for this if depression is the primary reason. And the safeguards at this time are that 2 independent physicians or nurse practitioners must examine the patient to determine if they meet the eligibility criteria, so there's still a process around that. And then there's a 15-day waiting period which can be waived, but in most cases, just to ensure that this is a durable intent of this person. And the provincial monitoring and recording requirements are being determined. So every health authority, every College of Physicians and Surgeons is busy kind of designing and what information will be available, how is that accessed, what does referral look like, etc. So just to bring this back down is, so what does person-centered care at the end of life look like? I think all of us would agree that we all need to be more actively involved in knowing what our choices are, and to be able to and be empowered to have those conversations with healthcare providers. In the US, they talk a lot about best possible day. And when we ask people, that has often very little to do with whether you want this medical treatment or that one. It has a lot to do with who you are as a person in the community that you live in, the family that you love, and the people that are around you, and how do we help all of us make that possible. It includes support for family, and introduced early, it can make a difference. So what can you do? So be informed. And so as the BC Centre, we're really promoting tools that help people be empowered to make their choices be the ones they want them to be. So what are the benefits? What are the risks? What are the alternatives of the treatments you're being offered? What does your gut tell you is the right thing for you to do? And what if we did nothing? Or what if we waited? Or what would be the next steps if we're going to talk about this again? So that you really are an active participant in making the choices that are right for you. Advanced care planning, as we've said, is that way in which this communication begins to be grounded in you and your choices. So talk about your wishes and preferences. I've just had a colleague be diagnosed with cancer, and she said nobody would speak to her. Her husband refused to speak to her. Nobody would speak to her, and she was desperate to have these conversations. But there's lots of fears, there's lots of stigmas. They're difficult to initiate. And so as a society, we need to make this more something that we integrate into our planning. Goals of care and thresholds for change. At what point would your goals change when you're living with a chronic illness and you know already that at some point you'll be facing predictable choices, so that you inform your families about how to make the choices that are right for you, the timing to stop or refuse treatments. And if you have a durable intent to refuse certain treatments, you can record that in an advance directive in British Columbia. So that's for people who don't want blood products, who don't want X or Y. You can record that in an advance directive, and that is legally binding. And we can utilize the supports and the resources that are available, and we can work to make more of them available. We can support those who express a wish to hasten death. Not in all cases. We've heard that half the cases, these are not made because of any kind of physical, psychological, or spiritual suffering, but often, half the time, patients are suffering from a loss of self, from fears of dying, from a desire to live but not like this, that they see death as the only way that they can end their suffering, or as the only way they can exercise control over their own life. And often this is something that is best explored in community, in families who are there to support the person. We can talk about the things that we don't like to talk about. So Pauline Abrams, ethicist in Toronto, has said, we're a death-denying, grief-illiterate society. We think it's optional to suffer grief and loss, and yet all of us, as we saw at the beginning, have suffered losses. And so how do we begin to talk about that? In Ireland, as part of their Compassionate Community campaign, they did posters in pubs that said on the one side, dying for a beer, and on the other side, 10 ways to support a bereaved friend. We need to start to have this be part of what we know how to do. And you can be part of the change. Compassionate communities work with each other to effect change and empower each other to provide the care and supports for vulnerable people in their local communities. This morning we talked about people who are vulnerable for multiple reasons. They're there among us, lonely and isolated, and we need to be able to welcome them into a supportive community. Thank you very much.
So we have about 20 minutes for discussion and questions and comments. And you can direct your comments to either or both of the panelists. Yes.
Thank you so much for the presentation you made this afternoon. The fact that the vast majority of the public may or may not support assisted end-of-life situations doesn't really address the fact that there's an incredible amount of denial on the part of the public that it's required. The fact that the people who are most vehement in their denial are very often addressing, or at least they claim to be addressing, the question of abusive hastening the end of life. How, given the fact that there are not that many here in this room, should we address that fear that's out there? Thank you.
Is that a question for me?
Sure.
Okay. I'm not used to speaking. Is it on?
Yes.
Okay, thank you. Thank you for your question. I think that there is likely to be less abuse the more we talk about end-of-life issues. I think there is likely to be less abuse of our elders and our frail people, older or not as old, if these are topics that can be talked about within families, among friends, with our physicians, with our caregivers. I think that abuse comes from out of desperation. I fear that abuse comes out of situations that people find themselves in that feel overwhelming, that they don't have support, they don't know who to turn to. I totally understand the desire not to set ourselves up as a country where frail people of any age get abused. For sure, that's not the Canadian way. That's not really our thing. But I don't think that clear laws and clear, open conversations will lead to more abuse. I think it will lead to people feeling stronger, feeling more heard, and I personally believe it will lead to less abuse. That's my feeling on it.
Doris, did you want to make a comment?
I think we know that about 80% of the concerns at end of life are social. 20% of the time is it a medical issue that bring people to the doctor. That's been well shown in studies. So I do think in this compassionate communities movement that we're part of, most of the time the changes that are necessary to support people well are not that expensive. It's just a different way of looking at the problem and mobilizing resources and usually information. People often, so the story is people either get nothing or they get 100 casseroles because that's how you respond to someone who's been bereaved, but a more nuanced approach. And just, using our technologies to schedule visits and to schedule and to just support people. I think we need to be more creative, and I think that's going to be the way that as a society we meet the demands that are coming. And if you're more aware of what's going on with your neighbor, then the chances that, some unscrupulous person is abusing them would become more evident as well. Rather than not knowing each other, we would become more aware of what is going on.
Next person, please. Please identify yourself.
My name is Johanna Trimble. I'm with the Patient Voices Network in BC. I wanted to thank Sarah for your very moving sharing of your family's experience.
Thank you.
I have some questions for Doris. I think one of the problems with end-of-life care is there are a lot of different agreements and terminology and forms. And I think the public gets very confused, or maybe it's just me, about what all these are and how they relate to each other and which ones are more legal than others. I also wanted to comment on the fact that I know families who have been traumatized by the end-of-life care in the hospital of their loved one. It's something we really have to look into. So, Doris, I'm wondering if you can tell me the difference and how these relate to each other between the MOST form, medical order for scope of treatment, what is a substitute decision maker, what's a representation agreement, and what's do not resuscitate, and how those relate to each other.
So prior to working in the BC Centre, I worked as the program medical director for end-of-life care in Fraser Health, and so we were the original people that introduced MOST. So basically what that grew out of was in our health authority at the time, we had a do not resuscitate form. That's the commonest form used across Canada to say, if I'm found to be dead, if my heart has stopped and my breathing has stopped, do you want to be brought back to life again using machinery and having support from an intensive care unit? We realized that that really, for most people, isn't the key decision. It's really, we needed to add to that decision in terms of the decisions that led up to that point of dead. When you're dead, do you want to be brought back, versus what kind of medical treatment and what scope of treatment do you want prior to that event? And so MOST was a system driver. I mean, it's not the be and the end all. It stands for Medical Orders for Scope of Treatment. Came from very successful similar projects in 38 out of 50 states in the US, where it's a way to document ahead of time the common decisions that need to be made about medical treatment. And I can tell you, I just spoke with a colleague, it has changed a culture where now conversations about what do you want as a patient are more normalized. I'm not saying they happen all the time. Prior to implementation of MOST, about 45% of our charts had a DNR order when we did a kind of a snapshot, and 67% had some evidence of conversations. But now those conversations aren't in a progress note somewhere in the social workers or the nurses' notes or the doctor's notes. They're on a form, and there's another similar form, that's the Advanced Care Planning Record, where you can write down where the conversations, what's important to this person besides whether you're going to have a feeding tube or not, or so on. So it's just a way of recording and making real within the medical system, because that's how it works. So when we implemented MOST, the goal really was to say, we don't just need a DNR form and a no CPR in acute care and a no CPR in community, and we still don't know what to do with someone in residential care or whatever. We need one form that is in all settings of care. And that when a family doctor has the conversation, that form can get faxed in and entered into that patient's chart. We're trying to kind of hardwire choice into the system around the level and the scope of treatment. The other choice that's probably the most common thing that's recommended is, for many of us, we may not know ahead of time what we want, because who knows what's going to happen. I'm young, I'm healthy, what's going to be the need for decision in my case, but I can appoint someone to speak for me who knows me well. If I didn't write that down, there's a kind of a legal way that that person gets identified by healthcare providers. So it's usually your spouse or all of your children, or kind of, and down the list we go. If your choice is that it's someone who may not be recognized by the healthcare system, you're a single person, you want to appoint your best friend who knows you best, but they wouldn't be on this list, you can appoint them in a representation agreement, and that is a formal legal document to say, I want this person to speak for me at that time. And that person, and I've heard stories, a friend, she started the advanced care planning program with me in Fraser Health, Sue Grant. She was a rep for quite a few people, and most medical people didn't know what to do with her because she'd say, I'm the rep, I have decision making, and people didn't know what to do with it. So there's education even in the healthcare system we need to do around that.
Thank you.
I just wanted to say that most people think that power of attorney is the same as a representation agreement, and it's not.
It's not.
No.
So if you could explain the difference.
Yeah, so most of us might do a power of attorney for financial issues, but rep agreements come in two types. There's one where you can make usual sort of medical treatments for someone, and then there's another type where you actually can appoint someone to make end-of-life decisions. So if that's your intent, you have to do that in a separate form, because the legal form around it, who's your executor and who's entitled to make financial decisions for you, is very separate and completely different than medical decisions. So thank you for pointing that out.
Thank you. Next, please.
Yes, I'm Eva Wadolna. I am member of the working group of physician-assisted dying, which is composed by Vancouver Coastal Health. It is composed of medical doctors, nurses, and senior administrators from hospitals, and some patients like myself, but I have some grounding in psychology, gerontology. And we discussed the legislation coming up, and I noticed, and I expressed it myself, that there is quite strong resistance of medical practitioners toward the whole subject. I also participated in town hall meeting with our Minister of Justice, and she's my MP, so I also talked with her before. I talked with her person. I sent her email just before second reading, and she simply indicated that NBC is extremely liberal as far as she is concerned, so we may not get our way. And what she meant was 3 points email from me, having 3 points. One is the clarification of language, at what point doctors can decide. Then doctors don't want to be called and they are signing up someone's death certificate. So they will lie in saying, well, I don't think person actually is going to die, because once they said it, person can start the process. The other thing was doctors don't want any correlation between palliative care and people choice. So if someone stays in palliative care, is well taken care of, but they reach the point and they want to actually die faster, they have to move out of it. And my friend had to move out from assisted living. Although she was very clear that she wants to die, she had to move and die in traumatic hospital circumstances. The other thing which I want to mention, there is the whole spectrum of things which are emerging right now, which allow people to talk about whole issue. One are dead cafe. I attended one organized by South Granville Senior Centers, but it was not my first one. I attended last summer that picnic in Stanley Park, and it was fabulous occasion for quite a number of people to talk in a relaxed environment. There is also one organization which I'm working with closely, a spiritual organization, which is going, so please watch it if you're interested, of announcements about discussions on death and dying, and showing the film that makes life possible. Film is made by Institute of Noetic Sciences in California. It deals with the spirituality and science and the whole process of dying. So there will be a lot of opportunities for people to express those things. One small comment related to advanced care planning. It is not part and parcel of representation agreement, because I have sought the legal opinion on it, and they said this is completely separate item and legally doesn't have bearing. So please kind of do not confuse people on it. And at this town hall meeting, yeah, I will have. And at this town hall meeting, expressly, doctors from Richmond too said, I'm not going to obey any directives coming from patients. What we are supposed to do in those circumstances? I understand conscious objections, but there has to be limit to it. because we have also conscience and we want
Thank
things
you
done.
very much.
So I would like your opinion.
There's a lot there to comment on. Okay, so I think prognosis is hard. I mean, and that's one of the things for especially specialists, it's really difficult because they like to be certain. And it's never certain, and we're mostly wrong. So I think to kind of predict when someone's going to die or how much time they have left is a very difficult thing. I think my understanding of all the different process with the health authorities and so on is to really ensure that the choice for physician hastened death or medical aid in dying is available. All health authorities now have canvassed to get the names of physicians who will be available to perform this, and I guess at this point the only thing that's clear, I think, is that faith-based organizations will not be included as a site of this, and so I think the rest is being determined going forward. Death cafes, death picnics, I think it's true, that's exactly the kind of grassroots thing that I think a lot of people are trying to promote, is this conversation in the public space. And as far as I know, the REP agreement, you know, with the legislation that came out in 2011 is legally recognized. I think it needs to be properly witnessed and signed and dated, but if it has all those criteria, but as I've said, it's still within the medical system not something we see very much of, and so often people aren't aware of what it actually means, and so lots of education still needed.
What's striking, it seems to me, is the degree of change that's occurred in a relatively short period of time. I mean, we've been having these discussions for years, but it's really this last short while that we've seen the grassroots effect. Do you have a comment you wanted to make, Sarah?
No, that's fine.
Okay. Yes.
My name is Helen Aqua, and I'm not associated with any organization. I have been, however, looking into advanced care planning, and it's opened up a whole bunch of doors of questions and obvious facts. Fact number one, my doctor didn't tell me about an advanced care planning document. I happened to find out about it some other way. If I do have an advanced care directive and I somehow land in emergency, no one knows I have an advanced care directive. That's a problem. I would like to think that everybody within 5 years' time would know the words advanced care directive as well as they know the words will. Everybody knows the question, do you have a will? Mm-hmm. And have you updated it? But nobody talks about, have you got an advanced care directive, and do you look at it once a year? Do you update it? Maybe you've named people or conditions or whatever treatment that have changed. So I just want to just put it to you, how do you think this can be put out there enough to make a difference?
We did receive some funding to promote this more public conversation, and we are working very hard on tools and resources that will be available in the public space to help promote this conversation. We've been training peers, members of the public to deliver workshops, forming a speakers bureau, and I think we're doing all we can to really, because that's I think the key message. We have to get it out there, and people need to know what they can do, and then we need to educate healthcare providers so when their patients and family members are coming with these documents, they know what to do with them. So there's a big job ahead of us, but I think often it's the public that drives policy and other changes, right? Because there's a demand for the product, and I think we're in that time now where that really, it's unacceptable that your wishes and your preferences aren't being honored and followed, and we need to really make that so now going forward.
Sarah?
Yes, I thank you for your comment, and I think it's a very important point. And I don't think, just as a member of the Canadian public, I don't think it's perhaps quite fair to expect the medical profession to do putting all the safeguards in place to make sure that my little document is known no matter where I end up in what hospital, possibly on short notice. I know that they're working incredibly hard to put that in place, and I appreciate it, but I think that part of it, and you've just played an important role right now, is the conversations. And I will tell you, my family of all families, we talk about death very easily. I was gardening with my dad on Bowen Island 3 weeks ago. And we were pulling up weeds because they're bugging him. So we're pulling up weeds. And he said, oh, and I went to the doctor last week and I got my DNR. And I said, well, that's great, Dad. And I said, I haven't got mine yet, but I should probably do that. And I said, where is it, Dad? And he said, oh, it's in my desk. And I said, okay. I said, so you've now told me that you have your DNR, and your doctor knows. Do you think maybe you could at least put it on the fridge? So my dad's DNR is now on the fridge. But so even in a family like mine, which talks very, very easily about these things, we miss stuff like that. And I think every person, every member of the public that goes, oh, you know what, you're my best friend. Can I talk to you about this? Because I want you to know. I want you to know. And then you maybe will have the conversation with your wife or your best friend. I think that grassroots is a part of it, an important part of it. I think we're partners here.
Thank you.
And thank you for your comment.
So we have 2 more speakers and about 5 minutes to go. So
Okay, great, thanks. My name is Hanif, and I'm with the BC Nurses Union. So this is a question just around Oregon, and I'm not sure if you can, Doris, you can actually speak to this, but you did talk about the fact that the vast majority, upwards of 70% of the folks who are accessing medical assistance to die have some degree of college or university education. And I just went and looked at the stats also, and 95% of the people over the past 14 or 15 years have been white who have accessed this. So I guess this raises the issue of accessibility. I'm just curious about your comments on this and whether or not you have any other light to shed on the numbers.
You know, what they've found when they've drilled down into the people who are choosing this option is that there's sort of 3 or 4 main things that typify someone who might pursue this in their research. I don't think it tells the story of all the different types of individuals, but people who don't have a real spiritual sense, that there's no meaning or purpose to this season of their life. And so people who find dependency more of a threat than death. They're fairly isolated. This isn't the stats in Europe, but in Oregon, it's more these self-determined kind of individuals. That tends not to be the experience of different cultures, particularly Eastern Asian cultures, who do things much more as a family and that sort of thing. Decision making is often shared in a different way. So I don't think it reflects that they don't have access. I think it reflects that this isn't sort of the option that they're choosing at this time. It would be interesting to look at Europe, because probably Europe's much more multicultural than possibly Oregon, although I don't know. So I think it's an issue we don't have a lot of data around at this time. We do know that in most cultures who feel themselves to be a minority, they're often also the cultures that advocate very hard for full treatment, because they're feeling somehow that a decision to offer less care might actually be discriminatory. And so it's quite a complicated issue for lots of reasons.
Yeah, can you just speak to the issue of education? Because I think that's, when I was talking about accessibility, it really was around issues of whether or not people who don't have post-secondary education maybe don't have access to the same information, or I'm just curious about that.
Well, I think, Alberta, for instance, has done a lot to make the information about how to access this sort of widely accessible and widely available. That basically, I think this will probably come to pass in British Columbia, that this will be something that most physicians are educated about. They know how to promote access if that's what somebody wants. There'll be sites patients can access directly with lists of physicians who can be contacted and so on. So I think it's something that because right now people are just struggling around the very basics of how is it going to happen and who's going to be available. And so in Quebec, I don't know, Quebec's got some early stats. I'm not sure to answer it. I think we're going to have to look at it in a year or two down the track when we have some evidence. And obviously education at this point, we haven't had a lot because we don't know what we're educating towards. The procedures and policies haven't been written.
Thank you. Last question or comment.
Thank you. My name is Al Wu. I volunteer for the Burnaby Seniors Outreach. The previous speaker asked about, if I have an advance directive, how does anybody know? Well, I inform the audience here that there's an organization in British Columbia called NIDUS, spelled N-I-D-U-S. NIDUS.ca is on the internet. NIDUS is apparently Latin for meaning nest. But you go to that website and it tells you all about representation agreements, Section 7, Section 9, RAs they call it, advance directives, also about wills. In fact, they offer a registry service. If you make a representation agreement, if you make an advance directive, you can register with them and anybody can search that registry with legal authority. That's information for the general public. Nidus.ca is the website. I have a question for Sarah. And by the way, thank you very much for your touching presentation about Jillian's case. In my view, Jillian was very courageous in choosing her exit strategy. A friend of mine also chose his. He put a gun to his mouth, unfortunately. But in this case, may I ask you this, and this is a personal question because you opened the door.
Yes, absolutely.
Yeah.
I'm fair game.
Thank you. Not fair game, but you know, they talk about suicide and suicide's other victims. And I don't know whether or not you feel that you're a victim or perhaps part of the facilitating process, but I often wonder when a suicide makes that fatal choice. In this case, Jillian suffered from dementia. Could next week, next month, or in the very short future, could there have been a cure or some sort of a miracle drug that would have solved her problem? And would you, as her caregiver, not have said, Mom, just hold on for a little bit longer and just bear with us? Now, there may be a miracle somewhere around the corner. Just don't make that courageous decision yet. Thank you.
Right. Well, of course, my mom didn't think she was courageous at all. She thought she was a bit of a scaredy cat. I don't feel like a victim of my mother's suicide, and I know that my brother doesn't and my dad doesn't either. We don't feel like victims of my mom's suicide. She made her decision lovingly and openly. There was much time for conversation around it, and we were ready. We knew when it was going to happen. My brother and I had a last weekend with her. Had I wanted to prevent my mother's death, I could have, right? Any one of us in the family could have. We could have hidden the Nembutal. We could have put it on a high shelf. Mom couldn't climb anymore. So there's no doubt I could have prevented my mom's death. And I chose not to because I honored my mom's choice. No, I never felt tempted. I did not feel tempted to say, hang on, Mom. What if October 2014 they discover a cure and you're going to be, I showed you some photos of my mom, right? You're going to be that lively person able to kick Dad's ass in an argument about Shakespeare once again. I didn't feel tempted. None of us felt tempted. You got to understand, my son died at 8 days old, so I'm not a big believer in miracles. I'm not a dark, depressive person, but I feel like I'm pretty realistic. At 83, my mom had a good run. She made her choice, and I honored it. And I honor her for having made it. And I admire her for having the guts to make all the publicity after she was dead. Genius. Genius.
Well, thank you very much, everybody. We could have this discussion for the next 2 weeks, but we're going to move on to the next session. Thank you.
Thank you.